Ansi, shall we start? It's
Yeah.
a practice session, right?
Ma'am, about a Mansi, countdown. Mansi.
Hello.
Good evening, Dr. Jaikumar. Good evening. Mansi, how are you starting?
Ma'am, we'll start in a minute.
Mansi. Mansi, can we start, please?
Ma'am, it's live. You can start. It's already live on YouTube.
Yeah, it's already live. We can start. No
Good
problem.
evening, everyone.
Pramila, please.
Yeah, ma'am.
Yes.
Ma'am, we can start.
Sure, thank you. So good everyone, and welcome everyone to another episode of Thyroid Clinics, which we do every Wednesday. So for today's session, I welcome our patron, Dr. R.D. Jaikumar sir, and I also welcome our President of Indian Thyroid Society, Dr. Sarita Bajaj ma'am. And to start the proceedings for today, we have Dr. Krishna Sheshadri, who is a Senior Consultant Endocrinologist at Apollo Hospital, Chennai. So he'll be taking us through the sessions. So we have very interesting sessions lined up for the next 1.5 hours. So please be there, and we will be talking about many things on thyroid. We have a journal club article to discuss. We have some interesting cases of thyroiditis. So please stay and listen to the talks, and also be part of it by asking the questions.
Good evening. Thank you very much, Pramila, and thanks for having me moderate this session. It promises to be something. It's a great initiative by the President of the Indian Thyroid Society, Dr. Bajaj, and you know, I think it's one of the first of many things that Dr. Bajaj is planning to do this year. She functions very effectively as a calendar reminder. I get messages saying, "Have you done it or not?" So I think, you know, that's a kind of a person we need to the help. And I think I'm going to be the same. I think our close time is 9:15, and the most important objective of any meeting is to go home on time. So with that, what we will do is we will call the first presentation of the Journal Club. And since there are two presentations, so what we will do is please make a brief presentation. Let's have a discussion. And then again, so we have two people speaking. One is Dr. Eram Nahid, a second-year senior resident from AIIMS Jodhpur, and Dr. Parth Jetwani, again from AIIMS, and please don't be afraid that your HOD is here. So, Dr. Garg.
Yeah. Good evening, sir.
Can we have the first presentation, please? Please make it brief, and we will try to make your life miserable after that. Dr. Nahid, start.
No, wait a minute. I'm sorry, Krishna. Parth will be talking first because that is a longer presentation, the T4 light.
Okay. Okay.
Okay, Parth, unmute.
Yeah. Okay. So I hope I'm audible and my screen is visible.
Yeah, you're audible. Please go ahead.
Yeah. Good evening, everyone. At the outset, I would like to thank the Indian Thyroid Society of India for giving me this opportunity to present this journal club. Good evening to all the respected faculties, delegates, and panelists who have joined in. So I'll be presenting the journal club for today. Myself, Dr. Parth Jetwani. I'm a second-year resident at the Department of Endocrinology and Metabolism at AIIMS Jodhpur. Yeah, so the trial that I will be presenting today, this was published recently in March 2022, and this was the T4-like trial, that is levothyroxine and euthyroid thyroid peroxidase antibody-positive women with recurrent pregnancy loss. This was a multi-center randomized double-blind placebo-controlled phase 3 trial, which was carried out in Netherlands by Mathik, M. Van Dijk, and colleagues. So just coming to a brief introduction, what do we know about prevalence of TPO antibody positivity? Worldwide, 8 to 14% women of reproductive age have TPO antibody positivity. When we look at specifically at women with recurrent pregnancy loss, 15 to 36% women have a TPO antibody positivity. Looking at recurrent pregnancy loss in general, approximately 2% women trying to conceive have recurrent pregnancy loss. So why is TPO antibody positivity important? Trials done since the start have found that women positive for TPO antibody have a higher risk of single pregnancy loss, recurrent pregnancy loss, unexplained subfertility, preterm birth, and postpartum thyroiditis. Now, this is just a brief summary of the trials which have been done, of the many trials which have been done, which have looked at TPO antibody positivity. And as you can see, studies done by clearly Goldman, Liu, N et al., Keroska et al., and Korevar et al. In all of these 4 studies and of the many that have been done, the odds ratio for developing thyroid, preterm labor or miscarriages have been significantly higher in women with TPO antibody positivity. As you can see in the study by Liu et al., which had a total of 3147 patients, which had selected healthy population. In women who had thyroid autoantibody positive, the odds ratio for miscarriage was 2.71, and this further increased as the TSS levels rose when in the subgroup of women with thyroid autoantibody positive with the positivity with a TSH of more than 5, the odds ratio increased to 9.56, and this was statistically significant. Again, at the other 3 studies as well, what we do know for TPO antibody positivity is that there is a higher chance of miscarriage, preterm labor, and premature rupture of membranes. So coming to the mechanisms as to why is TPO antibody positivity important and how does it eventually lead to these adverse outcomes. So we have 2 competing theories where TPO antibody positivity has been found to be associated with these outcomes. One of the theories is that chronic lymphocytic thyroiditis that has not yet led to hypothyroidism eventually develops during pregnancy, because as we all know, subclinical or overt hypothyroidism in these women can become apparent in early pregnancy because of the increased need for thyroid hormone. Second response, which is again that due to impaired normal physiological thyroidal response to chronic chorionic gonadotropin in early pregnancy, there is a relatively low free T4 in early pregnancy, which then leads to thyroid hormone deficiency. The other competing theory is that thyroid antibodies per se are a marker of hostile immune environment. So this was recently shown in a study by Korevar et al., where they went on to show that, as we all know, HCG tends to rise in the early half of the pregnancy. And in these women, as HCG levels rise, in women with TPO antibody positivity, they have a severely impaired thyroidal response to HCG stimulation. This severely impaired response then eventually leads to lower thyroid hormone levels in early pregnancy and a relatively low thyroid hormones, which eventually manifests as subclinical or overt hypothyroidism. So where are we at? So what we do know as of now is that thyroid antibody positivity has been associated with adverse pregnancy outcomes. But when we look at the impact of treatment of levothyroxine in these subgroup of women, there are conflicting recommendations from various society. When we look at recommendations from American Thyroid Association, that was 2017, what they recommend is that administration of levothyroxine to TPO antibody positive euthyroid pregnant women with a history of prior loss may be considered given its potential benefits in comparison with its minimal risk. While we look at other associations like the European Society of Human Reproduction and Embryology Guideline on Recurrent Pregnancy Loss, what they go on to suggest is that there is not enough evidence to support levothyroxine treatment outside of clinical trials. So while we are clear on the adverse effects which are associated with TPO antibody positivity, the impact of treatment of levothyroxine in this group of women remains debatable and there is conflicting evidence. So with this objective, this trial was taken up, and this was a multi-center randomized double-blind placebo-controlled trial, which was done in 15 hospitals, predominantly in Netherlands, one in Belgium and one in Denmark. The trial protocol and all subsequent amendments were approved by the Central Committee on Research and by the Ethics Committee of Amsterdam, Denmark, and Belgium. So what were the inclusion and the exclusion criteria? They included women who were aged 18 to 14 years of age with 2 or more pregnancy losses who were positive for TPO antibody and had TSH concentrations within the center's reference range. Now, largely, this reference range varied from 0.3 to 4.2 across various centers. There were fluctuations of around 0.2 to 0.3, but this was largely the reference range. What were the exclusion criteria? The exclusion criteria were women with a history of antiphospholipid antibody syndromes were excluded. If those women had a history of other autoimmune diseases or had a history of prior thyroid disease or had contraindications for levothyroxine use, they were then excluded. So how did they define pregnancy loss? They defined pregnancy loss as documentation of pregnancy by a positive pregnancy test in combination with clinical manifestations of pregnancy loss that was noticed by vaginal bleeding or cramping pain in the abdomen. How did they define recurrent pregnancy loss? 2 or more, not necessarily consecutive, pregnancy losses before 20 weeks of gestational age were defined as recurrent pregnancy loss. So now we move on to randomization. So women were then randomly assigned to either receive levothyroxine or placebo in a 1:1 ratio. So when they went on for the procedures at screening, an individual dosage was calculated based on the body weight and TSH concentration. If the TSH concentration was less than 1, levothyroxine was given at a body weight of 0.5 microgram per kg. If it was in the range of 1 to 2.5, it was given at a dose of 0.75 microgram per kg. While if it was more than 2.5, it was given at a dose of 1 microgram per kg. This dosage was rounded in half tablets, and the study medication was initiated before conception and continued till the end of pregnancy in the same dosage. So this is just a brief of how they went about the process. So women with a history of recurrent pregnancy loss who had TSH within the reference range and were positive for TPO antibodies were randomized into 2 groups in a 1:1 ratio. They either received placebo or levothyroxine. Simultaneously, they measured TSH concentrations of these women at 3 time points. That is preconceptionally, in the first trimester at around 12 weeks, and then in the second trimester at around 20 to 24 weeks of gestation. If during any of these time frames, the TSH levels increase to more than upper limit of normal for that reference, for that center, then the study medication was stopped and they were started on levothyroxine. However, if the TSH concentration continued to remain in less than upper limit of normal, they were then continued on their respective study medications till the end of pregnancy. So what were the outcomes? When we look at the primary outcome was live birth. That is a birth of a living child after 24 weeks of gestation. They also had specified secondary outcomes, which included ongoing pregnancy at 12 weeks, a pregnancy loss before 20 weeks of gestation, a preterm delivery, adverse events and serious adverse events, time to pregnancy, which is defined as the interval between the moment of randomization and the date of positive pregnancy test, and also survival at 28 days of neonatal life. So coming to the statistical analysis, when they looked at the previous data, they found that the live birth rate in women who were TPO antibody positive with recurrent pregnancy loss but had not received levothyroxine was 55%. Now, as we know, levothyroxine has been shown to reduce risk of pregnancy loss by 52%. So taking a previous study into account, they calculated the sample size so as to detect an increase of 20% in live birth from 55% to 75%, via which 90 women per group were needed, taking into account an alpha error of 5% and a beta error of 20%. They also took into account dropouts with a worst case loss to follow-up of 10%. And they expected that 10% of women in the placebo group might eventually develop subclinical or overt hypothyroidism and might need to discontinue medication. At the end of this, 120 patients were assigned to each group and 250 amounting to 240 patients in total. So for normally distributed variables, they were summarized as means with standard deviations. If the variables were not normally distributed, medians and interquartile ranges were reported. For dichotomous outcomes, they were analyzed with either Fisher's exact test or chi-square test as appropriate. For continuous outcomes, t-test was used for comparison of normally distributed data, and Mann-Whitney U-test if not normally distributed. So now coming to the results. So between a period of Jan 1st, 2013 and September 19, 2019, 187 women consented to participate and were randomly assigned to the levothyroxine group or the placebo group. There were 94 women in the levothyroxine group and 93 women in the placebo group. However, the trial was prematurely stopped because of slow recruitment when 187 of the 240 predefined patients had been included. So this is how they went about the randomization process. Initially, 187 patients were randomized into two subgroups, out of which 94 were assigned to receive levothyroxine and 93 to receive placebo. In the levothyroxine group, 25 stopped study treatment due to various reasons, and eventually 69 completed the study. In their outcomes, they have reported the outcomes with both intention to treat and per protocol analysis. And in the placebo group, as you can see, 93 were assigned to receive placebo and eventually 64 completed the study. However, in the analysis, all the 93 were included as per intention to treat. So when we look at the baseline characteristics of these women, what we see is that all the baseline characteristics, starting with general demographic characteristics, race, pregnancy history, and pre-randomization thyroid hormone concentrations were largely similar between these two groups. When we look at previous miscarriages, women in the levothyroxine group had a median of 3 miscarriages, while women in the placebo group again had a median of 3 miscarriages. So coming to the crux of this journal, which is what they eventually found out in terms of outcomes. So as you can see in the primary outcome, the live birth rate in both the levothyroxine group as well as the placebo group was around 50% in the levothyroxine group and 48% in the placebo group. And there was no statistically significant difference between these two groups. When they looked at secondary outcomes, starting with pregnancy at less than 24 months after enrollment with pregnancy loss, ongoing pregnancy, ectopic pregnancy, preterm birth, what they found was, again, these two groups did not have a statistically significant difference in terms of all the secondary outcomes. However, what I would want to highlight over here is when we look at some of the secondary outcomes, such as ectopic pregnancy or pregnancy of unknown location, because of the small sample size, as you can see, the confidence intervals are relatively large. When we look at pregnancy of unknown location, the confidence interval is ranging from 0.46 to 39.6. So because of the small sample size, the confidence intervals in some of the outcomes were relatively large. So having seen that there was no difference in live births, which was the primary outcome, then what they then looked at was what was the time to conception post giving levothyroxine in these two subgroups. So looking at this Kaplan-Meier curve, which shows time to conception in the x-axis and the cumulative conception leading to live birth in the y-axis, what they found was that the median time to conception leading to live birth was similar in both these groups. That was 9.1 months in the levothyroxine group and 9.8 months in the placebo group, which which there was no difference in these two groups in terms of the time to conception. So moving on to adverse effects, again, adverse effects in both these two groups, the total number of patients experiencing serious adverse events was similar, that is 7% and 8%, and none of the adverse events were related to the study drug and no study related deaths were reported. So coming to the discussion, as we have seen that there was no significant difference in live birth rate after levothyroxine treatment in women with recurrent pregnancy loss who were positive for TPO antibody compared with placebo. When they looked at the secondary outcomes, again, there was no evidence of a difference, including in all of the secondary outcomes, including pregnancy loss, ongoing pregnancy rates, and preterm birth. So just going through the strengths and limitations of the study, the strengths of the study was that this was a pragmatic study design because, as I had highlighted earlier, that as many as 25 patients, around 25 patients in both groups had lost to follow-up or had dropped out. So this reflects daily clinical practice, and the data was analyzed as per both the intention to treat principle as well as the per protocol analysis, and in both of these there was no significant difference in all of these outcomes. Also, another highlight of this study was that in contrast to some of the studies done earlier, there was preconception initiation of levothyroxine, which ensured that levothyroxine supplementation in the earliest weeks of pregnancy, and thereby this was better adapted to detect a change in term compared with placebo. Also, the generalizability of the findings are reasonable because they included women from multiple centers across high-income countries. Also, there was individual adjustment of the study medication dose depending on participants' body weight and TSH concentration. However, when we look at limitations of the study, a major limitation of the study was that there was premature termination of the trial due to slow recruitment, eventually leading to fewer number of patients being recruited. And how did this affect the trial? That estimates, as I had highlighted earlier, that estimates had a wide 95% confidence interval, and as a result of which the study might have been underpowered to detect a significant difference between these two groups in some of the outcomes. Also, specifically in one of the outcomes, that is pregnancy loss, that was one of the secondary outcomes, the absolute risk reduction in pregnancy loss was 10%, which then translated into a number needed to treat of 10, which because of the smaller sample size did not come out to be statistically significant, but this might again then warrant further studies with a larger sample size. Also, another limitation was that they used different assays for TPO antibody and TSH concentrations across various centers. So just coming to a brief review of literature now. So as we are all aware of the normal physiology of pregnancy, which usually happens, there is increased TSH concentration, which then leads to a 2 to 3-fold increase of TBG, and then leads to increased total T4 and total T3 concentrations, about 1.5 times the non-pregnant range. Other mechanisms being that because of similar homology of HCG and TSH, this HCG stimulates the release of free T3 and free T4, and there is a transient TSH decrease during 8 to 4 weeks and a transient free T4 increase during the same time. Also, there is increased peripheral metabolism of thyroid hormone due to increased activity of type 3 deiodinase, which then leads to increase in thyroid hormone demand. Moreover, other changes being that there is increased plasma volume and increased renal iodide clearance, which then subsequently leads to increased demand for T3 and T4. So this is about the normal physiology, and where are we at currently with respect to guidelines? So this is what the ATA guidelines suggest currently with respect to treatment of women who have when we look at specifically at women who have a TSH ranging from 2.5 to 10, what ATA advises is that we should go for a TPO antibody test. And if that TPO antibody test comes out to be positive, and then the TSH is between 2.5 to more than up till the upper limit of normal, we should consider treatment with levothyroxine. And if the TSH is from the upper limit of normal up till 10, we should treat with levothyroxine. However, in this same population of women, if the TPO antibody is negative and if the TSH is from 2.5 to upper limit of normal, no treatment is advised, while treatment can be considered if the TSH is from upper limit of normal up till 10. What they also advise is that the treatment
Dr.
remains...
You should wind up. We are past 20 minutes.
Yeah, so I'm just finishing off. Yeah, just a couple of just 3-4 slides there. So what they also advise is that treatment remains debatable with insufficient evidence currently which exists to conclusively determine whether levothyroxine treatment decreases pregnancy loss in TPO antibody positive euthyroid women who are newly pregnant, and administration of levothyroxine to these women with a history of prior loss may be considered given its potential benefits in comparison to its minimal risk. So where are we currently with respect to treatment? Just a couple, so the studies which were done earlier with respect to treatment, the first randomized control trial which was done...
I must request you to wind up.
Okay, so I'm just finishing off. So these were the initial studies which were done, which initially suggested that TPO antibody positivity, there was impact of treatment, while the initial 2 trials which have been done very recently, that is this trial, that is the postal trial, and thereafter there was this tablet trial which came into limelight. This was done in 2019 by R.K. Dillon, Smith and et al., which then went on to suggest the same thing, that levothyroxine treatment as such has no impact in terms of decreasing live births in TPO antibody positive euthyroid women. So I'll just come on to the take-home messages. What we know is that TPO antibody positivity has been associated with adverse pregnancy outcomes across various studies. However, the role of levothyroxine treatment for prevention of adverse pregnancy outcomes in TPO positive women remains debatable, with studies which have been done recently, such as the postal trial, tablet trial, and the trial which I've just mentioned, that is the T4 trial, suggesting that there is no benefit of levothyroxine in euthyroid TPO positive women, pregnant women. However, TPO antibody positivity could have a prognostic significance, mandating close follow-up of these women. That is it from my side, sir. Thank you.
Thank you, Dr. Jetwani. Are there any questions? I think from the senior members here, any members of the audience can put it on the chat box. And
untreated group, they have done very little monitoring. It is not like usually we check TSH every month in an antenatal woman. They have checked pre-pregnancy once during the first trimester and once during the second trimester. So whether
ma'am, TSH levels were thyroxine, but again, the difference was not statistically significant, but they were lower. It was 2 in the levothyroxine group and 2.1 in the placebo group.
Dr. Bajaj?
Yeah, thank you, Krishna. Parth, that was a good presentation. When we talk of trials, I think the gold standard is an RCT, right? So do we have any earlier RCTs in this context? The papers that you discussed, the literature, the review of literature.
So, ma'am, we have a total of 6 trials in total, and this is just starting out. That the first randomized control trial was done by Negro et al. In 2006, and there they looked at TPO antibody positive women, and they were divided into 3 groups. So what they found was that when treated with levothyroxine, the miscarriage rate was significantly lower. That is 3.5 in the group treated with levothyroxine. However, the caveat over here was that they had a small sample size, and also what they did was they used a fixed dose of levothyroxine, and this levothyroxine was not started pre-conceptionally. So this was the first trial which was done. Thereafter, a trial was done by Nazarper et al. In 2017.
No, I'm asking were they, except for Negro's trial, were the others RCTs?
Yes, ma'am.
Ma'am,
which have been done recently.
If I remember right, in this literature, there are at least 8 to 12 RCTs, all of them being very, very small.
Yeah, sample size.
The sample size is great. So this is an area where, where emotion-based medicine becomes more important than evidence-based medicine. Now, the second part is what we have to also consider is how many of these studies involve infertility. For example, the Negro data, right? There is also an enriched population that is there in the thyroid group. For example, you will find, for example, some of the Negro data will include, are not really this kind of studies, but looking at patients undergoing infertility. The third is many of these studies will not have live birth as an endpoint, but only clinical pregnancy as an endpoint. So there are all the studies in this area are fraught with methodological problems. The one nice thing about the study is, we've had about 600 women who have completed the study. But in fact, I was planning to ask Dr. Jetwani, now, how many of these patients were infertile patients, were subfertility or recurrent pregnancy losses?
So actually, that is what I was just about to come to. When we look at these 2 trials, that is the poster trial and the tablet trial, all the women that they did include had a history of infertility. In fact, in the poster trial, as you can see, all participants received treatment for infertility, and thereafter this trial as well, the tablet trial that was done over here as well, all the participants had a history of infertility. This is in contrast to the T-fold trial, which I've just highlighted. Over here, none of the patients had a history of, fewer patients had a history of infertility. So in both of these trials, they had a history of infertility.
I may not disagree, because I may be disagreeing because 60% of the patient was nulliparous. If you look at the data which you have presented, 60% of the patient was nulliparous in both groups, where they have taken the criteria of 2 to 3 pregnancy loss. So you can consider them as a infertile lady, rather than, there may be some other problems.
So, Dr. Jetwani, can I ask you a question? Why is it that you've given all sorts of explanation, but let me ask you from a physiological and importantly a biological point of view. Why is there so much importance to autoimmunity or TSH elevation to the thyroid with pregnancy, especially in the infertility group? Why do you think it is there?
So from the data that or the literature that I read was the mechanisms then what they went on to suggest was there eventually tends to be pregnancy as such is a immune activated state, and there tends to be hostile in women who are susceptible to autoimmunity. They tend to have a higher chance of other
Let me give
complications.
you a clue. It's got everything to do with the placenta. What do you think is happening? Have you looked at what happens in the placenta that makes the fetus so vulnerable to thyroid antibodies? Okay.
I'm not exactly sure about it.
Okay, good. So one of the interesting things, and that's why this is such an area of interest in this thing is, if you look at the placenta, you will notice and look, you take a picture of the placenta and take a picture of the thyroid and keep it close by. It is actually very difficult to distinguish the two because of the iodine synthopore activity that occurs in the placenta. The placenta is an area of exceptional iodine synthopore activity, and the way the concentration occurs, it's almost exactly like the thyroid. And that is why this is something very, very important. So I would recommend that you look at beautiful articles that were published in Infertility Sterility about 4 years ago. I'll paste this thing there, but that is the reason. Any other comments from people here? Dr. Jayakumar, you have a comment? There is one question in the chat box. Let me take it up. So the question is, what is the rationale in giving thyroid medication? The hormone levels are normal. Dr. Raghavan, I think I'll just summarize it for you. We have always been concerned that in the presence of thyroid autoimmunity, there is a greater amount of pregnancy loss, especially in infertile couples. And therefore, to see if suppressing the autoimmunity by giving thyroxine, and we don't know if that's happening. Remember that autoantibody levels are notoriously inaccurate. So that is a rationale. And at this point of time, there is really no clear evidence that this happens. The second question is I don't know if anyone else wants to comment on this, is that especially in controlled ovarian hyperstimulation, there is a very interesting thing that happens, especially in patients who are predisposed to thyroid autoimmunity, and that is that by week 2, the TSH climbs. Anyone has experience on this, and whether pre-treatment of these patients with thyroxine, does it help? Is there any data to support it? Anyone can answer this question.
Can I say a few words, Krishna?
Yes, please. We have about 2 or 3 minutes, yes.
Yeah. We had a meeting 10 years back, the American group, the Brazilian group, Asian group and all. This was the contention, that in a patient who is pregnant or likely to be pregnant with a normal TSH, antibody positive, should we treat or not? The Brazilian group are very vehement. They said when antibody is positive, we will treat. None of us agreed with it. And we said, do we have an RCT to prove those treated, untreated, what is the outcome and all? They said our guidelines, if the antibody is positive, we treat. Again, what is the rationale? The rationale is if you give thyroxine, antibodies production may less, but there is no such RCT or anything, or even a scientific data to say in a normal thyroid person with antibody giving early this, that it will suppress the antibody. I think it is purely hypothetical. That's why today we don't follow that guidelines when TSH is below 2.5, whether antibody positive, negative, treating a woman who is infertile and all, maybe more of emotional, as you said, or empirical treatment, hoping. And what does this study prove at the end of it? If that is the question, Jaitwani, what do you say at the end of this question, this paper, what is your conclusion for that question?
So I think we should be careful about inferring from a study that has not met its primary endpoint at all. The primary endpoint is that it's inconclusive, and I think looking at the subgroup, although it's not a hierarchical study, the subgroup analysis, I think each of these are very, very underpowered in this particular study. Dr. Jetwani, last comment, and then we have to move to the next presentation.
There is one question in the chat box.
One more.
Yeah.
Okay, 1 second. We have taken the chat box question. There's a Q&A question. 1 second. In the chat.
Q&A question, yeah.
1 second. Let's take a look at the chat box. When will we start the L-troxin in pregnancy? When will we start thyroxine in pregnancy? Clearly, when the TSH is more than And 4 is at this point of time the correct, or that is the upper limit of normal, is the correct indication. The time between TSH of 2.5 to 4 is a big if. There are people who would treat if there is a adverse obstetric history and or positive antibodies. I think those are probably level B to C recommendations. A type A recommendation is a TSH that's more than 4. Ashish Shepal, how can we ask, how often can we ask for thyroid tests in pregnancy if anti-TPO positive antibody is positive? Dr. Pramila, you want to take this one?
Yeah, if the antibody, if the patient's antibody is positive, but the patient is euthyroid, then we do a baseline, then we follow up in 2 months and do one more. If it is normal in the second trimester, then we normally don't have to repeat too many times. But in the first trimester, yes, after 6 weeks to 2 months, we repeat once to see if there is a rise, because that's the time when we need to just follow them up.
Okay. I think we are eating up on the other presenters' time. Pramila, thank you. And what we will do is get the next presenter on board. I'm sure she has a wonderful presentation to make. Can we have the next? Can you start, please? Yes.
Iram.
Dr. Iram, please. Are you there?
Yes, unmute yourself.
Is my slide visible?
Not yet. Not yet.
Not yet. You have to click on the, yes, your presentation.
Just click on your presentation slide. The full desktop is available, visible. Just click on the presentation slide.
Iram,
My
click.
slides visible?
No.
Not yet.
We can see your full desktop. Now we can see something. It's coming. I think.
Now we can see nothing.
It's not gone. It's gone. Yeah.
Yeah.
Now.
Yes.
Yeah, but we want
Yes.
a
Now-
slideshow.
Yes. Now
Good
go ahead.
evening. Good evening, everyone, respected faculties, panelists, and colleagues. I will be presenting a short case of middle-aged female who developed subacute thyroiditis after COVID vaccination, followed by a brief literature review. So this is a case which I have taken from Journal of Endocrinological Investigation, which was published from PGI Chandigarh. Coming on to the case detail, the patient is a 47-year-old female with no previous comorbidities. She presented with complaints of fever and neck pain for last 2 weeks. The fever was moderate to high grade, continuous, and it was never recorded. And the fever was associated with neck pain, which was radiating to the jaw. She also complains of restlessness, difficulty in swallowing, and weight loss of around 3 kg in this duration. There is a history of administration of first dose of Covishield 2 weeks before starting all these symptoms. On examination, patient was having tachycardia with a pulse rate of 110 per minute. Blood pressure was 130 by 70 millimeter of mercury. She was febrile with respiratory rate of 16 per minute. The next examination shows a tender goiter of WHO grade 2 with no palpable lymphadenopathy. In systemic examination, cardiovascular system examination, respiratory system, central nervous system examination was all normal, and per abdomen was non-tender with no organomegaly. The patient was investigated accordingly. The thyroid function test revealed high total T3 of 2.2 nanogram per ml with upper limit of 2 nanogram per ml, total T4 of 12.9 microgram per dl with upper limit of 12 microgram per dl, and the TSH was suppressed of around 0.06 micro international unit per ml. Patient was anti-TPO negative, and she was also negative for thyroid receptor antibody. Ultrasound neck was also done, which revealed a bulky thyroid gland with hypoechoic nodules of around 1.5 into 1 centimeter in right lobe and 0.8 centimeter in the left lobe, without any cystic changes, any calcification, or any increased vascularity on Doppler. The patient underwent the thyroid scan, and the thyroid scan revealed no radiotracer uptake in the thyroid gland. She underwent a FNAC from the right-sided thyroid nodule, and this FNAC was suggestive of granulomatous inflammation. So according to the history of fever and neck pain with thyrotoxicosis in biochemical picture with reduced uptake in radioactive in thyrotechnetium scan and with FNAC suggesting of granulomatous inflammation, the final diagnosis of subacute thyroiditis, probably because of COVID vaccination, was kept. And it is because of the Asia syndrome, which I will be discussing in the subsequent slide, which is the autoimmune or inflammatory syndrome in response to adjuvants. Patient was managed conservatively with 40 milligram of propranolol daily. There was gradual improvement in her restlessness and she gained weight, and along with resolution of her neck discomfort. She was reevaluated after 8 weeks. At that time, there was complete resolution of her presenting features. The thyroid function test was normalized with normal total T3, normal total T4, and TSH became normalized to 1.5 microinternational unit per ml. And the repeat thyroid scan now revealed the normal thyroid function with improved trapping function when compared to the previous scan. So coming on to the discussion, Asia syndrome is a new syndrome which is described in 2011 by the Schoenfeld. It is an autoimmune or inflammatory syndrome in response to adjuvants. Adjuvants are used in vaccine to enhance the immunogenicity of the vaccine, to increase both innate and adaptive immune response. And these adjuvants which are used in vaccine, it can induce the formation of antibodies or inflammation which can be localized or systemic in genetically susceptible and predisposed individual that can manifest as autoimmune or inflammatory syndromes. There are multiple endocrinopathy which are reported along with the Asia syndrome, and most common are related to thyroid in the form of subacute thyroiditis, Hashimoto's thyroiditis, Graves' disease. There are some rare case report of primary ovarian failure, autoimmune type 1 diabetes, and autoimmune adrenal gland insufficiency after vaccination, mainly of hepatitis B, human papilloma virus, and influenza vaccine. Coming on to thyroid disease as a part of Asia syndrome, it is relatively uncommon, but patient can present as Graves' disease, Hashimoto's thyroiditis, and subacute thyroiditis. And subacute thyroiditis as a part of Asia syndrome has been reported with hepatitis B, human papilloma virus vaccine, and influenza vaccine. And in COVID vaccine, the Asia syndrome has been reported as early as 3 days following the vaccine or as late as 21 days after the vaccination. Most commonly reported after the first dose of COVID vaccine. The probable mechanism is because of the activation of the autoimmune cascade leading to the polyclonal activation of B lymphocytes, or there can be molecular mimicry of the viral S protein to the human antigen. And also there is an abundant presence of ACE2 on the follicular cells of thyroid, which can bind to the vaccine associated S protein. Also, there has been found to be the cross reactivity of antibody against S protein of COVID with the TPO. The thyroid or other organ can be affected because of the bystander activation, the antigen non-specific process, which can result in activation of the autoreactive T cell, which cause destruction of the cells, leading to the Asia syndrome. The largest systematic review of the subacute thyroiditis developing after the COVID vaccine was published recently in January 2022 in the Journal of Endocrinological Investigation by Ippolito et al. They found 51 patients who developed subacute thyroiditis after COVID vaccination, out of which majority was female, 74.5% were female. The mean age of diagnosis was middle age, median was around 39.5 years, and the subacute thyroiditis developed after a median duration of 10 days. With interquartile range of 4 to 14 days. 29 patients developed this syndrome after the first dose after median of 10 days. 20 patients developed after second dose after median of 6.5 days, and 1 patient developed after the third dose with the median of 20 days. 66% patients were vaccinated with mRNA vaccine, that is Pfizer vaccine, which was most commonly associated with subacute thyroiditis. 18% patients received the viral vector vaccine, that is Covishield. 12% patient received inactivated vaccine, that is Covaxin, and 4% patient underwent heterologous vaccination. And they also followed up the patient, and they did found that after 4 to 8 weeks of follow-up, thyroid function was available for 38 patients out of 51 patients, and around 42 patients became euthyroid in 4 to 8 weeks. 26% were still hypothyroid and 31% were thyrotoxic. After 8 to 16 per week of follow-up, TFT was available only in 10 patients. 40% was euthyroid, 4 patients were hypothyroid, but 2 were still having TSH suppression. There is another systematic review recently published by Jafar Zadeh et al. In March 2022, in which he have analyzed the thyroid dysfunction following vaccination with COVID-19. And he did found that the most common vaccine which was associated with thyroid disorder was mRNA-based vaccine, that is Pfizer, in 68.7% of the patient. Then next in frequency was vector-based vaccine in 15% patient, and inactivated vaccine in 14% of the patient. Thyroid disorder was most common was subacute thyroiditis. Next was Graves' disease, focal painful thyroiditis, silent thyroiditis, and other rarely associated was thyroid eye disease, painful thyroiditis, overt hypothyroidism, or atypical subacute thyroiditis. So the take-home message is a subacute thyroiditis following COVID vaccination, although rare, is a possibility which should be kept in mind. And subacute thyroiditis is usually a mild self-limiting condition, and the possible association with vaccination should not deter people from COVID-19 vaccination. This is all from my side, sir.
Excellent, Ram. Absolutely, you are right that this should not deter from getting the vaccinations against the COVID, and that's the same opinion I held with you. Thank you.
So can I start off with so what was the imaging that was used in determining subacute thyroiditis in this patient?
So technetium scan was used to.
So can I ask you, are you aware of any limitations of technetium 99 scan in subacute thyroiditis?
Sir, in subacute thyroiditis, usually there is a decreased uptake in subacute thyroiditis.
That occurs with both iodine 131 as well as.
Sir, in case of recovery phase, or if the patient is a hypothyroid or euthyroid phase, the technetium scan can show increased uptake, even in case of subacute thyroiditis.
Okay. So I think we need to be a little careful with technetium scans, because in subacute thyroiditis, because they can cause patchy uptake, right? As opposed to iodines, where you actually find uniform decrease in uptake. Technetium scans are known to have issues. So I'm just raising this flag about technetium 99 scans in the acute phase of subacute thyroiditis. Now, let us say you never had a nuclear scan. What else can we use?
Sir, we can look for the ESR and CRP, which are usually raised in case of subacute thyroiditis.
What imaging can we use?
Sir, we can go for ultrasound thyroid and Doppler thyroid. Normally, it decrease. Sir?
Go ahead.
Yes, sir. There is either focal heterogeneous mass lesion, or there is a diffuse heterogeneity in case of subacute thyroiditis. And also on the Doppler imaging, there will be decrease or absent vascularity to the thyroid.
The absent vascularity has a higher predictive value. Excellent. So I have one more question. Did they justify why they did an FNAC on this particular patient? Would you do an FNAC in a subacute thyroiditis patient?
Sir, ideally not to do, but just to prove that it is a subacute thyroiditis, they did a FNAC from that nodular lesion.
Okay, so what? So they just saw a granulomatous lesion, right?
Yes, sir.
Is that classic of subacute thyroiditis on FNAC?
Sir, pseudo giant cell can be present in case of subacute thyroiditis. There will be a colloid which is surrounded by histiocytes, which is the classical histopathological manifestation of subacute thyroiditis.
Dr. Iram, can you stop sharing the screen?
Yes, ma'am.
So, but is that what they found on the FNAC? The FNAC says something else, right? It says granulomatous thyroiditis.
Yes, so they mentioned only granulomatous thyroiditis. They have not mentioned it clearly, or they have not given any picture of the histopathology.
Exactly, isn't it? That's very interesting. That there are other causes of granulomatous thyroiditis, including in this country, tuberculosis.
Yes, sir.
So I mean, I was just a little puzzled that this could happen. So in your patients who present, you would not do an FNAC, correct?
No, sir.
Okay. The other question is, so do you think that this is much more common with mRNA vaccines, or is it just that, you know, in that this thing, just a large number of patients came from places where Moderna vaccine was used more?
Yes, sir. It is from US, only Pfizer vaccine has been approved. So more of the people are giving Pfizer vaccine. So it may be a confounding factor that mRNA vaccine is mostly associated with subacute thyroiditis.
So you know, personal anecdote, I had two patients who had presented. One interestingly was scheduled for surgery because this person had a nodule, and they did exactly what was done here. They did a FNAC, and it had a Bethesda 4. So you really don't want to be doing an FNAC in somebody who's thyrotoxic, because the FNAC will show altered cells. So it was read as a Bethesda 4. Patient was scheduled for surgery. Then we got the thyroid indices. In fact, this was a colleague and teacher of mine who we saw a few months ago, and we did a radioid and uptake, which showed it was low. The ESR and CRP were elevated, and then you know, this patient he still has his thyroid intact. Long story. And this person had Covishield. So we had two patients with Covishield. I'm sure others have some interesting things to share. Arun, Prasanna, Dr. Bajaj. Dr. Bajaj, your hands is up.
Yeah, Iram, I have a question.
Yes, ma'am.
See, what is the role of corticosteroids in the management of thyroiditis?
So, ma'am, if there is severe symptoms of neck pain, patient can be given prednisolone 40 mg per day or as low as 15 mg per day can cause resolution of the symptoms. And if the patient does not resolve after 24 hours or after giving steroid, then the diagnosis of subacute thyroiditis is questionable.
Yeah, because in the management, at least I don't think they give, they just give propranolol.
Yes, sir. Yes, ma'am.
Case.
Yes, ma'am.
So it depends on where you train. Dr. Prasanna Kumar is here, and he and I have had famous fights about this. So I'm a big believer in steroids. Dr. Prasanna Kumar poo-poos it. Both have their benefits and risks. So the disappearance of symptoms is much faster with steroids. However, there is a risk of recurrence of symptoms also in patients who are put on corticosteroids. But one of the best tests for subacute thyroiditis is if you start the patient on steroids and the pain and the symptoms go away in 24 hours, then it is subacute thyroiditis. If it doesn't, then it is. But I think for 20 years, Dr. Prasanna and I have had fights on this. And I think we will fight till you know, one of us leaves upstairs. So maybe we will fight even when we both go upstairs. So, but this has happened for many years.
I've had patients, presenting with PU, pyrexia of unknown origin, low grade, and eventually somebody got a thyroid profile, a little hyper, went in for a scan, confirmed thyroiditis, and then like steroids, they actually work like magic, like for that short term. The patient symptomatically and in all respects improves very fast, and it's going to be short term anyway. Max, I would give it for 6 to 8 weeks and then taper it off, and that's the end of the story. Yeah, we have some questions in the chat box. I think the one of the questions has already been answered. Why do an FNAC in a clear-cut case of subacute?
So you mean patients with autoimmune disorders are at auto-antibody formation, this vaccine may be deferred. I don't think a vaccine should be deferred just because of the risk of autoimmunity. And please don't check autoantibodies, thyroid antibodies in patients who are undergoing vaccination. We already have people measuring CRPs and other things before vaccination. We don't want this also to be done. Please don't measure antibodies in patients who are undergoing vaccination. I think that should be a take-home message. Remember, this is a very small number. Dr. Iram, what is the incidence of vaccine-associated autoimmune of subacute thyroiditis based on your reading of the literature?
Sir, it is around 2 to 3%.
Of the total vaccines, I doubt it.
Sir,
that's an overestimate.
Yeah, it is 0.0002%.
It is 0.0002%. 2 into 10 to the power of -5. So,
And we have to be sure that it is vaccine associated. That is also the big question, because there are so many viruses which are implicated. So we may think that it is vaccine associated because the temporal correlation may be there. That's the only thing we have. But many a times it may be just a viral, because during some seasons in Bangalore, like we get a lot of thyroiditis. So during those seasons, if the patient takes the vaccine, whether it is a chance occurrence because of the vaccine or because of some other virus, is also difficult to comment. So that is also the problem.
I mean, in Bangalore, water hyacinth associated thyroiditis probably more common than vaccine associated thyroiditis. See, it is lovely for endocrinologists to have more diseases, but I think this is not one of them.
Yeah.
So interesting.
180 crores people have taken vaccine in India. If it is 2%, I think all of us should have seen 500 patients per day.
Yes.
Absolutely.
And you can't have thyroiditis and sit at home simply. It is just
Look, when I was reviewing the papers on the subaccute thyroiditis, I told the publishers to publish it after 1 year, when the COVID is over, not to create a scare among the patients who want to take the vaccine.
Right.
So we should not get scared of these things. If it occurs, we can treat it. No problem.
Since we are talking
we need to, Dr. Bajaj, is this burning? I'll permit it. Not burning, we put Amit on it.
Just for clarification, there are a lot of doctors who start steroids when they see TPO antibody positive. I just want to tell them that for TPO positivity, we do not give corticosteroid. That's just one message I wanted to convey. That was all. I have seen prescriptions, with the antibody positive, because of the I think it's autoimmune, and you have to give steroids for that. So there is a myth out there which needs to be corrected.
Just to conclude, if you're thinking of measuring anti-TPO antibodies, think again and don't measure it, right? So I think that should be really our take home. With that, can I get Dr. Amitabh Arya in my former colleague at SRMC, and he's going to talk about low uptake thyrotoxicosis today. Dr. Arya, all yours. Unfortunately, we've eaten a little into your time, but I'm going to still ask you to finish on.
Sure, sir.
Can we help Dr. Arya, please? Please share your screen, sir.
Yes, I'm doing that. Yeah. Yes, sir. Can you see the slide, sir?
Yeah, we can see.
We can see all this.
Just have to make it full screen. That's it.
But it is not in the full screen mode yet.
Fine, sir?
Yes. Yeah. Now it's full screen. Yeah.
Yes. Yes, sir. Good evening, everyone, and thank you, the organizers of ITS, and thanks, ma'am, Sarita Bajaj, ma'am, for giving me this opportunity to talk to the august audience. And I discussed with ma'am, the topic was initially interesting cases of thyroiditis, but unfortunately, in nuclear medicine and thyroiditis, mostly you don't see anything on the scan. So I thought of giving a full array of patients with thyroid scan. With due permission, I start. We know about this pituitary thyroid axis. I need not discuss it. We have been reading it for a long time, and this is just a pictorial presentation of thyroid hormone synthesis. And we are seeing the trap. Basically, in thyroid scan, what we do, we see the trapping mechanism and the organification defects by the thyroid scan. Yeah, this is sodium iodide importers.
I'm not able to hear him. Can you hear him?
Yeah. Can you hear me now, sir? Hello. Can you hear me, sir?
Yeah.
So this is a scan, and we have these importers: the thyroid, salivary gland, stomach, small intestine, lactating breast, mammary gland, and Here we see the uptake as in our nuclear medicine studies. Now, the clinical scenario in thyroid is hyperthyroidism, thyroid nodule, and hypothyroidism. We need to know the clinical indications, the radiopharmaceuticals, the pathophysiological basis, contraindication procedures, findings, and interpretations in our nuclear medicine scenario. Now, we come to abnormal thyroid function, overt or subclinical hyperthyroidism. DD of hyperthyroidism, that is distinguishing Graves' disease from toxic nodular goiter, determining the therapeutic dosage of iodine-131, predicting the outcome and potential side effects, differentiation of thyroiditis and hyperthyroidism, evaluation of multinodular goiter for hyperfunctional hot thyroid nodule, and cytologically indeterminate nodules to identify a benign autonomous functioning thyroid nodule. Now, we use 3 agents primarily in nuclear medicine. Pertinatate is most common, 2 to 10 millicurie, depending on the body weight, IV route. It is trapped but not organified. Image is taken 20 minutes or 1 hour later. Half-life is 6 hours. Gamma energy 140 kV with the image by the gamma camera, and with the radiation dose is 0.13 rad per millicurie. Iodine 123 sodium iodide is not used anywhere in the country because of its high cost and availability. If we use mostly in the Western world and Europe, it is used. It's 200 to 600 microcurie. Oral route, we can see trapping mechanism, defects, and organified. It is organified and trapped as well. So, the imaging is 4 to 24 hours, 13 hours the half-life, 159 kV gamma emission, and you get radiation dose of 0.007 rad per microcurie. Iodine 131 is used very commonly in India. Sodium iodide 50 to 200 microcurie given orally, trapped and organified by the thyroid gland. 4 hours to 24 images, 8 days half-life, 3 to 4 kV gamma emission, and 1 to 3 rads per microcurie. And is also a beta emitter. Now, between the weighing balance of pertinatate and iodine 123, we use technetium pertinatate most commonly, and the scan which Dr. Naik showed, it was a pertinatate scan done in PGH Chandigarh. Advantages is tilting for pertinatate. We can see the trapping, readily available rapid test procedure, and it's cheap. Disadvantages, sometimes we see esophageal or vascular activity. It is not organified. For when we see esophageal activity, streak is there, so we tell the patient to take a glass of water. So it dissolves away. But coming to iodine 123 iodine, which we don't use in India, advantages, you see the trapping and organification, better image in low count, physiological tracer. Disadvantages, long imaging time, availability, and it is very costly. Precautions for the test of pregnancy, breastfeeding. Pregnancy should be ruled out. Avoid pregnancy for 6 months after radioactive iodine administration. Avoid breastfeeding after radioactive iodine. Radioactive excretion is there in stool, urine, saliva, vomit, as well as perspiration for 48 hours. Flush the toilet twice after urinating or defecating for 24 to 48 hours after procedure. Avoid public transport and sitting close to others. And carry documents indicating the date provided of information that are used while traveling, because suppose you go to the airport, normally they screen, and suppose radiation level is high, so you can be screened. So if you have the documents, it will be fine. Now, how we do the scan by the gamma camera, you see a patient lying down the gamma camera. This is our department in GPGI. So instrumentation, you need just for the thyroid imaging, you need a gamma camera equipped with a low energy all-purpose or leaf collimator or pinhole collimator. Supine with neck extended patients who are unable to lie down, we can take it in a sitting position. Pertinatate, we inject, and 15 to 30 minutes, you can take the image. And iodine 23, is imaging is 3 to 24 hours. Anterior, left anterior oblique, right anterior oblique views are taken. 500,000 counts is fed, or 5 minutes image is taken. We use radio opaque markers to identify anatomical landmarks, tunnel notch, thyroid cartilage. So you have a better picture and you give a better report. And for the location of palpable nodules as well. Duplicate views should be obtained without the markers. This is a normal scan and uptake. You can see a thyroid scan. We put a marker here. These are the and right and left anti-oblique images. Then we take out the up. Then the counts are taken. We make a background region of interest and region of interest around the thyroid gland, and we see the uptake. Yeah. So there's increased uptake. So this can be hyperthyroidism due to Graves' disease, early stage of Hashimoto's thyroiditis, iodine deficiency goiter, recovery phase, subacute of thyroiditis, lithium carbonate therapy, withdrawal of anti-thyroid medication, rebound after suppression of thyrotropin, and congenital defect of thyroid hormone synthesis. Decrease uptake. Most common it is in thyroiditis, because when we have a thyroiditis, we see image like this. So it can be decreased uptake in the thyroid scan, can be in primary and central hypothyroidism, thyroiditis, all destructive subacute silent postpartum, parenchymal destruction, and post-thyroidectomy or ERT to the neck, chronic thyroiditis, excess iodine uptake, medications which inhibit the uptake by the thyroid gland is radiological contrast, amiodarone, topical iodine application, antithyroid drugs, perchlorate, thiocyanate, sulfonamide, and you also have thyrotoxic versus lactatia. Now, the nodules, as per the ATA 2015 nodule, more than 10 to 15 millicurie, THS subnormal. German endocrine surgeons, as per 2011, say thyroid nodule more than 10 millimeter, any TSH value will do. As per ASC 2010-16, TSH less than the lower reference limit, and iodine deficiency TSH is less than 1 to 1.5 MUI per liter. The function of hyperfunctioning cytologically indeterminate cold nodules to identify those at higher risk of malignancy, determine the degree of function in the thyroid nodule that is palpable or found incidentally at the imaging procedure. Now, this is what we find in the thyroid scan. This is a hot nodule, which we call on a thyroid scan. Significant uptake, suppressing rest of the gland. Malignancy rate is less than 5%. In a cold nodule on a thyroid scan, we see a cold area here in the left thyroid lobe. This is no or minimal uptake, between 20% in malignancy. We advise always for FNAC from this area. And warm nodule, it has more uptake than the rest of the gland without suppression. Now, this is regarding the what we find on the radiological ultrasound grading. I think I will not go into the detail of the ultrasound grading of the thyroid gland. These are we see the composition, echogenicity, shape, margin, equation, foci, and then we grade 0, 2, 3, 4, 6 points, and more than 7 points. Yeah. So coming to the cold nodule, most thyroid cancers are hyperfunctioning and therefore appears cold nodule on thyroid scintigraphy. Majority of our cold nodules are benign, up to 80 to 90%. Specificity of this finding for the diagnosis of malignancy is low. Any hyperfunctioning thyroid nodule is evaluated on its sonographic features according to TI-RADS classification. AFTN is very rarely harbors malignancy. Indeterminate cytology, for example, Bethesda classes 3 and 4 is frequently reported. In a prospectively study of 615 AFTN, more than 80% of AFTN were classified TI-RADS more than 4. Moderately suspicious, requiring FNA for nodules more than 1.5 centimeter. Only 16% of AFTN were classified as TI-RADS less than 3. To summarize, we have cold nodule, something we see like this on a thyroid scan. Here, in a Graves' disease, we see increased uptake, but also we also see a pyramidal lobe. In toxic MNG, we have hot and cold nodule uptake like this. As a hot nodule, in autonomous functioning nodule, we have suppression of the whole of the right thyroid gland, and it is taken over by the left thyroid gland. And in thyroiditis, radiation uptake is less than 5%. We see something like this. Sources of error can be local contamination like clothing, skin, hair, collimator crystal. We have to see this as a nuclear medicine physician. Esophageal activity, suppression of iodine uptake by interfering substances. Evaluation of congenital hypothyroidism, iodine deficiency, thyroid dysgenesis, ectopia, hyperplasia, agenesis, defect in thyroid hormone synthesis, dyshomogenesis, hypothalamic pituitary CH, and transient, that is iodine overload, maternal antithyroid antibodies, or antithyroid drug intake. Now what we do normally is like thyroxine discontinued for 4 weeks, then it would PT4 TSH normal, then we go for thyroid ultrasound normal, then TFT in 4 weeks normal, then TFT in 4 months normal, then we have transient Okay. Then if you have an abnormal FT4 or TSS, thyroid ultrasound, then it's abnormal thyroid gland, then we have a permanent, we have to do the therapy now with radioiodine. Then this, it's normal, then peripheral discharge test. And we have a whole plethora of the protocols as per the, this is as per the Journal of Pediatrics in issue 5 by Erika A. Houston. Now this is normal site as uptake here. I mean, this is we normally put a marker like this so that we can see the enlargement or the whether it's crossing or suppressing or not. And this is normal site increase uptake, normal site with decrease uptake, and this is no uptake. This is ectopic. There we have a lingual therapy. Now we do peripheral discharge test, and this is for the iodine organification defect, which presents with high early uptake sensitive to peripheral intake. A reduction more than 10% of radioactive iodine level at 2 hours after oral addition of sodium perchlorate is considered positive for an iodide organification defect. Partial iodide discharge of 10 to 90%, total iodide discharge greater than 90%. This is our scintigraphy. The low radioiodine uptake in thyroid salivary gland. We have iodide transporter defect and disconnected to the gene mutations. Normal radioiodine uptake with positive peripheral discharge. Iodide organ infection defect. Total the TPO gene mutation partial. This again we have these few gene mutations. The normal radioiodine uptake with negative peripheral discharge. We have TG iodine recycling effect. Then we TG, IYD, DHALI, and gene mutations. Now, how would you do thyroid uptake? It's a non-imaging method to measure the radioiodine uptake only. Radioiodine uptake is used for differentiating different hyperthyroidism, detecting iodine organ infection defects with the perchlorate discharge test. We place iodine 123, or in India we use iodine 131 capsule in neck phantom. Acquire count for 1 minute, record the counts, time of equation, administer capsule to the patient at 6 hours, probe in front of the patient neck, acquire count for 1 minute, time of equation. Thigh count is taken as a background measurement. We repeat the same at 24 hours. Normal 4-hour radioactive iodine uptake is 5 to 15%, and normal 24-hour radioactive iodine uptake is 8 to 35%. And these are the different what we find in the imaging and PSA suppressed homogeneous, more than 30% graves, iodine 131 available on request. Suppressed T cells again homogeneous, 4-hour up to more than 30% for 11 4 hours. Graves with rapid turnover, iodine 131 therapy available on request. And suppressed homogeneous 10 to 30% mild graves, non-elevated radioactive iodine uptake can also be secondary to exogenous iodine source. And the suppressed again heterogeneous with code or code nodule. Any here is toxic MNG iodine therapy on request. Suppressed single hyperfunction nodule with significant decrease uptake within the main gland. Any that is autonomous nodule. So here we have iodine therapy on request. Suppressed single hyperfunction nodule with slight decrease uptake within remain of gland. Any suspect autonomous nodule, consider T3 suppression test for confirmation. Suppressed, usually not a chronic process unless acute or chronic, no significant bladder activity less than 5%. Thyroiditis. And we can do a follow-up on TSH. Mildly suppressed, improving, then we find a faint glandular activity, 5 to 10%. Recovering thyroiditis, again follow-up on TSH. Thank you so much, and I'll tell a sloka. Varna kritani chitre padani tu pade pritani vakyani vakya kritam vapatram shastmedam na purasmavi. Means the small varnas create a text creates small shlokas make big shastras. I'm nobody to say anything, but small words make up the entire shastras. Thank you so much.
And indeed, small words, but sweetly done, giving a very, very beautiful overview of what we have.
Thank you. So
Dr. Arya, I remember some discussions with you almost 17 years ago. Very interestingly, too. One of them is that there used to be a trend that even when you ordered an iodine 131 scan, that nuclear medicine people would supplement a technetium along with it. Why is it, and is that still being followed?
No, so actually, we are doing.
Is it because of the collimator, or is it because of?
No, so right now what we do is basically we do a particulate scan. So we don't do iodine scan anymore. what we do if we want to see the organification defect, then we go give a 50 to 100 microcurie of iodine orally and do a iodine scan. Otherwise, we are doing automated thyroid scan, and we have different collimeters definitely.
Is that because? But the thing is that there can be discordant scans, especially with the hot nodules between technetium and iodine, can't they?
Yes, sir. But sir, primarily we use now coordinated scan, in whether it's a cold nodule, hot nodule, or a warm nodule, and we do a thyroid uptake definitely with the radioiodine if you want to see the organification defects.
Okay.
Yes.
So you in SGPI, PGI routinely you do not do 24-hour radioiodine uptake.
No.
Not at all. Okay.
No, sir. I mean, when we have that, we want to see the because this will tell the trapping mechanism defect, TCO4. And when we want to see organification defect, then we go for radioiodine uptake study using that uptake machine, or we can do a scan also with iodine 131. Yes, sir.
Any other questions? I don't see anything in the chat box, but any other questions?
Yeah, Amitabh, thank you. I enjoyed your presentation.
Thank you, ma'am.
See, the problem that we face here is that of course, a scan was not possible till 2 years back. And then, of course, even ablation becomes very difficult. So the tough part was how to differentiate between a Graves' disease and a patient with thyroiditis, that is the tough part. So I think at least a scan is mandatory if you're not able to differentiate between these.
Yes, ma'am. Yes, ma'am.
Yeah.
Actually, what we do, ma'am, when after taking a proper history, normally the thyroiditis patient does tell about pain or some fever, and then he had a fever or a pain. Or when we take a proper history, then we come to know that he has taken some medication, and many times the cough syrup which has got some iodine and all. And when it's a frank thyroiditis, then there's no uptake. And normally we do a coordinated scan, and we are very easily able to demonstrate between the Graves' disease and thyroiditis, because there's no visualization of thyroid at all in thyroiditis. It can be due to the disease or due to any exogenous drugs which is taking, or iodine contamination, or I've seen many times when the patient is taking Ayurvedic or homeopathic medication, the uptake is not there.
So, very interesting. Just to sort of summarize for people
Yes,
who
sir.
do not have access to scans, one of the simplest ways to distinguish between low uptake and high uptake thyroiditis is to get a history and see the symptoms are there for more than 3 months. If the symptoms are there for more than 3 months, it's very highly unlikely to be a low uptake thyroiditis.
Yes.
And I think that's a simple rule of thumb that people who do not have access to nuclear medicine scans. But if you have access to Dr. Arya, then you should use it. We've had again discussions. I still prefer to do uptakes, 24-hour radioiodine uptakes, and I continue to do it. There are others but most of India, I think, prefers to just do a technetium test and you scan. It again depends on where.
But sir, I agree with you. Ideally, iodine uptake is a much better way of saying a 2 hour, 24 hour, 4 hour. That uptake is a very important test, which I'm seeing slowly it is fading away. I don't know why, but I think I still after doing a thyroid coordinated scan, because the half-life is 6 hours, you can do next day. You can do an iodine uptake, no problem with that. Because
so it's got everything to do with this, with the speed or the speed of the world, right? Some of us are old clinical thyroidologists and believe in the classic way of doing things.
No, sir, but iodine uptake,
new generation.
Definitely, no, sir. Iodine uptake is definitely important, and it should be done regularly. No doubt about it. No doubt about it.
But I thought you would be able to answer why we are no longer doing it. Is it a lack of availability or expertise?
It's not lack of availability, ma'am. Now in the gamma camera itself, we have some software by which you can calculate the percentage of the uptake. You give orally 50 to 100 microcurie of iodine 131, make the patient lie down, and you take the image and you can calculate the uptake. But I myself still think that thyroid uptake probe should be there. Every department should buy it, because we had a thyroid uptake system. We are planning to buy it again because it was almost 12-15 years old now. Now we are going to buy a new one.
So you have a pinhole or a leap collimeter?
No, sir, we use a pinhole collimeter, but we also have a pinhole collimeter, but primarily they use leap only. But pinhole, you have a better image. Definitely, it magnifies it 4 to 5 times.
Absolutely.
But due to the patient surge, we are doing 30 to 40 cases daily, bone scan, renal thyroid scan. So just for the laziness part, the resident doctors, I'll say, many times when you push, you change the to pinhole collimeter, then they do it. But that is the ideal way. If you use a pinhole collimeter, you have a better picture. And ideally, you should do a thyroid uptake study with a proper thyroid uptake probe.
I know we are running late, but I'm not going to let you go till you ask one more question. Have you, one of the things that have been noticed in the last 30 years is a reduction in the population thyroid uptake itself. There was a time when 35% was the upper limit of normal, but you don't see those numbers anymore, isn't it?
Yes, sir.
Right, and Bortovsky used to think that this is because of iodine supplementation in the population.
I think yeah, iodine supplementation, and number two, the fast food which we are eating is in the fast food also pizza, burger, they put a lot of iodine. I read a exhaustive article on it. Maybe we are over supplementing them. I don't know, because we don't find that as serious. Those classical cases we don't find it.
No, we've heard of that hamburger thyroiditis. Yeah, but I don't know, but that was long back, wasn't it?
It was in 83 to 87.
Yes.
But actually, that day when Dr. Raman Marva was talking about that iodine supplementation in the salt, he was telling that because government mandated it, that there has to be this much minimum supplementation. So what has happened is the companies have over supplemented the salt. So that is also because what exactly they were planning to reach at the consumer level, much more is reaching. So over a period of time, I think the population is getting overexposure now because of that as well. That's why now they're coming back with the guideline that it should not cross that level. Till now it was that it should be minimum that much. Now it should not cross that level. That guideline will come up for the salt supplementation.
So that's because there's a loss of iodine during
even after that also they were telling that it's more. So that is one thing also they were telling could have led, because what they planned for the population much more has been given up over and above that. That's what they were thinking.
So any time that the iodine supplementation policy changes, there is usually an outbreak of either toxic MNGs or thyroiditis. So we are in for good times to be it's a great time to be a thyroidologist. And I'm happy that Dr. Bajaj brought up the Amber Thyroiditis, because it is like Jon Snow pulling out the cholera handle, where the symptoms, and for young people listening to it, it is a classic in epidemiology.
Yes.
And it is only fitting that we end with. In fact, Dr. Braverman was involved in this thing, and one notification by the U.S. Department of Agriculture saying no more gullet trims stopped the epidemic. So with that, we have had such a wonderful presentation. I would love to thank both the presenters, the young endocrinologists who have presented such a wonderful two wonderful journal articles, but also have taken so much time to prepare and give us an evidence-based perspective. To them, I'm very grateful. You were very thorough, exhaustive. One piece of advice is that if you say everything that you know, then you become boring. So hold back a little. With that, let me turn it on to Pramila to take it home. Thank you so much.
Yeah, thanks, Dr. Krishna. It was really nice. We all enjoyed and learned a lot of new things as well. So I think Dr. Sarita Bajaj ma'am would like to give the concluding remarks for today.
Yeah. So I would really like to thank you, Krishna, because you added life. It was a T4 life trial, but you added life to the entire session. And it's because of you that we've had this wonderful discussion. Thank you. Thank you so much. Thank you, Dr. Garg, for joining us. And Dr. Prasanna, I'm sorry for the inconvenience that that link was not working, but I really admire your spirit, and thank you for being with us. Dr. Jayakumar, both our presenters, Parth and Iram. That was a very nice presentation and a good choice of, I think, articles as well. Amitabh, again, a
Thank you.
very good presentation. And
Thank
I
you
think
so much, ma'am.
the take-home message as far as thyroid scans are concerned has been very, very well conveyed.
Thank you so much.
Thank you to Minnie, to, of course, Pramila. She's going to be always with us for every meeting because she's the scientific chair. And then, of course, we have our digital partners. Mansi is with us, and we also have addition on board, that is MediSage. Thank you, Rahul, for being with us. And Madhukar, a very, very special thanks to you for organizing the entire session as far as the Journal Club is concerned, and for joining us as well. Thank you all. Thank you very much.
Thank you too.
So looking forward to the next edition, which is going to be session 4, and that is going to be on hypothyroidism, all about hypothyroidism. Thank you. Thank you very much.
So much.
Good night. Good night, everyone.
Good night, everyone.
Thank you so much.
Good night.